Hello and welcome to Triage, rapid legal lessons for busy healthcare professionals, a podcast created and produced by K&L Gates. Each episode is designed to highlight important developments in health law and analyze the impact on our clients and friends of the firm. We hope you enjoy this podcast.
Carlos, thanks for speaking with me. I wanted to ask you to start off by discussing a little bit about your background and then describe Yakima Valley Farm Workers Clinic, and then I'll move on to some more specific questions for you.
Okay. Thank you for having me. I am honored that you have chosen to interview me, and I hope I will not disappoint your listeners. My name is Carlos Olivares. I'm the Executive Director of the Yakima Valley Farm Workers Clinic. This is an organization that has been serving low-income migrant and seasonal farm workers and communities of color for over 40 years. I have been in this position in the Yakima Clinic for 37 years. And our organization today operates 40 independent outpatient systems that are spread throughout Washington State as well as Oregon State. Last year, we served over 200,000 people and generated over 700,000 medical dental visits throughout our system. We employ over 2,300 folks that are working not only in delivering medical care, but also we do a lot of social work. We do a lot of outreach into our communities. We do education, nutritional, behavioral health. We are a licensed mental health system, as well as the only designated foster care program in this valley. We take care of all of our children with special needs in the Yakima area through our clinic called Children's Village, as well as we are the only clinic in this valley that serves HIV clients. It's called New Hope, and that clinic has been operating for, 20 years, I guess. And so our primary purpose in our mission is really focus on delivering care to the underserved communities in the valley. The valley is a rich agricultural area whose economy in great part depends on the agricultural industry. And over harvest time, we can have as many as 40,000 migrant and seasonal workers that harvest the food that we all eat. At the same time, we suffer from some unique problems that are manifested because of that immigration, but also because we are an agricultural community and farmers have been rather reluctant to give up their land to build housing, and particularly low-income housing. So we suffer tremendously from lack of affordable housing in our community.
Okay, let's talk for a second about COVID and how it's impacted Yakima and your patients in particular. Tell us a little bit about that experience.
Well, it was an interesting sort of experience so far in that early on, we anticipated some of these problems as I'm sure everybody in the country that began to understand the developments of this pandemic starting in New York and moving through our country. But we recognized early on that we had to be prepared for what has come to be our reality today. And that was that a lot of transient, a lot of moving parts in our economy and our people coming and going, and the lack of education about what this really is and how it's going to impact us. So we got prepared fairly early, and in some ways, unfortunately, that has paid off in that Farm Workers Clinic has done over 6,500 tests from the beginning, and we have reported over 1,300 positives in our area. We've also seen that the industry that dominates the economy is beginning to really hit hard as it relates to COVID. The number of positives that we are experiencing in that industry is exceeding 27%, and in some cases, the hot spots are showing as much as 50% positive return on the testing that we are doing. It's a small community, so hotels and restaurants have been hit hard, that we don't have that many, but every one of them closing has put a lot of very low-income people out of a job. And unemployment filing here has hit over 16% in the last couple of weeks. The biggest impact, I think, what we are experiencing, hence the tremendous amount of need for food in our community, is that many of the workers that were employed in the service industry were undocumented. And because of it, they found themselves without an ability to apply for unemployment and are finding very difficult to sustain their families and where they live and what they eat. So in the healthcare side itself, the impact has been meaningful and significant. Farm Workers Clinic alone anticipated that between February and July, we will lose about $10 million worth of revenue. We had to shut down dental. We had to shut down all of our other programs, nutritional programs, educational programs, diabetes. Kids are not coming to the clinic or to the dentist. And so it has had a big impact in what is happening. With a 2,300 workforce, we have furloughed quite a few of our employees and attempted to keep them employed by allowing them to use sick leave and vacation time, et cetera. And so that has had an impact in not only in our clinics, but in the community as a whole. We are one of the largest, of course, employers in the area, and as such, anything we do has huge economic repercussions. So the most striking thing that I could say about the impact in the community is that the lack of understanding of what this is and what it does. We have a very young population in our community because not too many 65-year-olds go take on the farm or work in the warehouses. And so it's a fairly young community, and they are invisible. So it's very difficult to inform them, to communicate the gravity of this. And we are struggling trying to make that point that this is not the flu. And they have, unfortunately, received so much misinformation over the last few months that they're grasping for any and every information that they can get a hold of that tells him something different than what the CDC is saying or that we're trying to communicate. So we don't know, hence the reason we haven't peaked yet here, and we don't know when that will happen. Today, we saw 129 positive cases. We are the highest contributor to the Northwest positive testing, and so we don't know. We're in the middle of it, so we don't know where this will end.
So coming into the pandemic, I know that you were involved in some pretty innovative projects. So I wanted to focus a little bit about the innovation that you've brought to the community in the past. And then we can maybe talk a little bit about how you think you might be changing or innovating going forward. So I know that you've had a mail order pharmacy. Can you tell us a little bit about that and how it got started and why you started it?
Yeah, I mean, we operate, over 15 pharmacies in our own clinics, very busy pharmacies. And what we were experiencing is because of the lack of transportation and, the inability of people just to get to the pharmacy, we began to see a tremendous amount of non-compliant prescription management by our patients. And so also, the cost is always a factor in that. And so we began to explore the possibility actually of contracting with somebody to do mail order delivery. And a lot of skepticism about that. But at the end, when we evaluated all of the options and the alternatives for mail order, it occurred to me that there's nothing that they are doing that is frankly rocket science. It's pretty straightforward sort of structure and delivery system. There's a great deal of technology involved in it. And we decided that we'll give it a try, right? My philosophy has always been, if somebody else can do it, there's no reason why we can't do it. And so we started the mail order delivery. Today we have over 150,000 people who are receiving medications. We will exceed 1.6 million prescriptions delivered via the mail. The interesting part about this is the COVID has made this even more popular among our community. And so we will probably end the year, we expected 1.6 million. We will probably end the year by doing close to 2.6 million prescriptions at the end of the year. The wonderful thing about this is that we didn't really have to train our patients to get used to the idea of having something delivered at their home. Thank you, Amazon. They made a fantastic job at training just about everybody in the world about delivery and how reliable and how comfortable it is to engage in that practice. And so we had absolutely no trouble at all jumping in with this, and people immediately took on the idea of having their medications delivered. So that was very helpful to us, and I think it was one of the innovative projects that we embarked on and was very successful. Moving forward, the pharmacy, I think, is going to increase in its capacity. However, there is a whole host of changes that we will have to make in the healthcare delivery system moving forward. We are already looking and investigating the possibility of the technology that's currently available. For example, dental visits, remote dental visits. And those are possible. Particularly, we are interested in nursing homes and senior centers where we could take our dental hygienists and do dental examinations, do fillings, and transmit all of that to our dentists in the clinics who could assess, evaluate, and guide our workers in the field and provide dental services. We have lots of portable equipment. We also are going to intensify our mobile units. We have 3. We're buying 2 more to do in Oregon and the migrant camps, and Washington, we have several migrant housing that we will begin to go to the patients rather than the patients clustering in a exam room or in a waiting room in one of our clinics. So those are some of the changes we are seeing. The need to build administrative facilities, for example, seem to be more and more remote. We are seeing that most of our employees who were not frontline essential workers were able to work from home and do it incredibly effectively. So there is absolutely no reason why my billing clerks, for example, need to have a building to work on. And so we are rethinking our 2 or 3 construction projects that we have. Each were in the tens of millions of dollars to put together. And we're just going to improve our technology and make our workforce as much as possible operate and work from their home. Those are a few of the things that we're seeing in terms of change.
So how do you think these changes will impact the cost structure that you have in delivering care to your patient population? You're caring for a lot of people.
Yeah, I think that, one, I do not believe that the number of people that we're seeing in the clinics is going to significantly decrease. I think we are anticipating that maybe 10 to 15% of the current patients that are going to the clinic will stop going to the clinic. And we will be doing and continue to do remote visits. We're doing video visits, we're doing telephone visits, and patients are really enjoying that. So there is still, of course, the need for clinics. They'll be a little less crowded, and probably our ability to serve them will be better. We need to build a separate workforce that deals with remote access, remote consultation work that will not be in need of exam rooms and MAs and nurses. Will be operating even from their own homes managing the calls, managing the visits from the patients. What the cost structure will change a little bit in that we have to beef up and improve even more the technology. So at the beginning, the costs in technology will be higher, but the savings on the other side of not needing 3 nurses, 4 exam rooms, and a bunch of receptionists to manage that volume of patients, I think will offset the initial investment that we are making now, actually, on our Epic system. And what will that mean for us in the future financially? We are still not quite done with that analysis.
So let me go back to the issue you just mentioned, which was the separate workforce for people who are dealing with patients remotely. When I've spoken to other folks, other practitioners who have adopted telehealth during this time period, and it's worked out well for them and their patients. I don't think that they particularly enjoy dealing with patients remotely when I talk to them privately. So tell me why you wanted to have a remote workforce and a in-clinic workforce, because I haven't heard other people talk about that.
Well, I think that the in-clinic workforce there's no way that you could, it's just my opinion, but there's no way that I've worked with these folks for 40 years. There is no way that you could be in a profession that requires to some degree a touch and a face-to-face sort of assessment of patients' needs, and the delivery system itself is set up to manage that. Many of the folks that have gone to school to do this clearly are not interested in talking to a computer and then fulfilling the same fulfillment that they do when they're touching their patients, when they're talking to their patients face-to-face. However, there is, I believe, another group of people who are more comfortable doing it that way. Reminds me of the change in attitude technology that, for example, our radiologists have. Maybe, Carla, you're too young to remember, but radiologists actually used to have offices and used to have, you have to go there, they'll show you the x-rays, and they did stuff like that. Today, there are very few that operate that way. Most of them don't see patients at all, or hardly any. They may consult in the hospital a little bit, but there is no longer these radiology offices unless they're taking imaging. And even if they are, it's the technicians who are doing most of that work. And the radiologists are reading their x-rays and whatever other radiology work that they need to do at home. So there is this element of opportunity for some who are not interested as much in complicated patients and patients that are, they have multiple comorbidities that they have to deal with when they are on a one-to-one, and rather than have these much less complicated this, doc, I have a cold, what do you want me to do? Or I'm a diabetic who has his diabetes under control, just checking with you on a month-to-month basis. Let's take a look at your lab, look at your medication stuff. How are you feeling? Everything is good. We're going to redo your medication stuff. You're done. So there will be, and I think there are many that we are anticipating and seeing today, that are feeling way comfortable managing patients that way, as long as they are not really complicated patients.
So, we hear a lot about the great migration to telehealth during this time period. And some people are thinking that post-COVID, that there will be a significant change in the use of telehealth. I'm gathering that you're not predicting as great a change as other people might be thinking of.
I don't think so. I do think that there will be a significant increase of telehealth from what we knew before. No question about that. But I am not in a position. I'm not in a place where many may be that says 80% of your visits will be telehealth in the future. I seriously doubt that. I think people go to see a doctor or go to a healthcare facility because they want to have a face-to-face interaction with someone that they trust, someone that they know, someone that has followed them. My God, my children all deliver with one obstetrician, and their children are being delivered by the same obstetrician. So there is this sense of loyalty and friendship to some degree that develops within the profession. And I seriously doubt that will be replaced by telehealth. There are some things you can't do via telehealth. There are elements of the visit that are really personal, and they are human relations that are not easily captured in a screen.
All right. So are there other things that you've learned about delivering care in this unsettled time?
Yes, I think how quickly we as human beings seem to get tired of something that it is absolutely clear and undisputable, and have this inherent ability to pretend it's no longer there just because we're tired. And I think that moves on into other issues in healthcare that we perhaps never thought about them that way. I think that there may be conditions such as obesity, right?
Yeah.
That people just get tired of hearing how fat they are. And eventually they become numb to that message, and very difficult to re-educate, re-engineer the way in which we address those issues. And that is, for me, going to be one of the moving forward lessons. We need to intensify the integrated models that speak to people outside of the four walls of the exam room about their healthcare conditions that are medical in nature, but they're not curable by a doctor. But they are influenced by other people who have been trained and are more attuned to how to speak to people that suffer from those conditions. A nutritionist is way more prepared, knowledgeable, and better at telling people about their weight than a provider is. An OBGYN is going to say that you're obese, you shouldn't do this, it's going to hurt you at the delivery, it's not good for you, it's unhealthy, go get skinny. Okay, I like to hear that message 9 months out of the year as I am getting bigger and bigger. Not going to happen.
But Carlos, don't you worry that in kind of a divided America, which is where we are now, that rolling the costs for these counseling and lifestyle management issues into the healthcare budget is something that some part of America is going to resist significantly?
It can, and I think it will. However, my experience, for example, in managed care for the past 25, 30 years is telling me that if you bundle a premium that allows you to have the flexibility, putting the resources where they need to go, rather than where you get paid based on RVUs or encounters, that you build that flexibility in such a way that it really focuses putting dollars where they're going to cause the greatest impact. My patients today are getting, I think, better quality of care, and we've demonstrated that by the reports that we have around improving quality for our patients, by deploying resources that have very little to do with the doctor's work, but have everything to do with improving, for example, housing for one of our patients. Emergency housing is critical for those who are coming out of an injury, those who are coming out of surgery, that have nowhere to go, or the places that they're going that are completely inadequate for recovery. And they end up back in the hospital immediately. And so if we can provide them emergency recovery housing for a period of a month or two until they are back on their feet, then we've avoided hospitalizations that cost hundreds of thousands of dollars. And we're beginning to quantify that. We are tracking that data, and we believe that we very soon will be able to create that value-based proposition that connects all of the dots between obesity, nutritional care, and medical care, for example, or housing, or transportation, or medication compliance. These are elements that are so needed And they will also begin to help us balance to some degree the inequities that we are seeing among populations of color, among low-income people that are impacted by, their healthcare is impacted by these issues that happen around them every day in their lives.
So that requires building pretty robust and discrete financial systems that capture the right data and map it to the right patients. And so that's what you're doing.
That is absolutely what we believe creates a stronger, much more consistent system. However, if I don't have control of that portion of the dollars, then I am forced to stay where I am, which is I bill for an encounter and I do as many of those as I possibly can to make as much money as possible. And the outcome of the patient's care is important, but it weighs much less than the ability to stay open by simply billing the heck out of everything.
You've long been involved in receiving kind of first dollar premium to cover your patients one way or the other. Yep. And so you're advocating strongly for having access to that revenue so that you can deploy those revenue in a way that's most efficient in terms of patient health.
Yep. We have double, if not triple, our capacity to take care of patients because we have been good stewards of that money. Doing so, we have not only increased our capacity, but we have increased in a way that we can demonstrate the quality of care that our patients are receiving. Our satisfaction scores hit never less than the 90th percentile. And we survey over 7,000 people about their visit within 24 hours to 48 hours of their visit. And what I know is that without having that capitation, that element of flexibility for me to deploy the resources where I need to, that would not be possible.
Well, I've always thought data is really important to achieving health care for a community. I think that sometimes gets lost in the conversation.
Yeah, I mean, people get appalled, for example, when I say we didn't go to a hospital to buy Epic. Epic is a very expensive system. But we wanted to control the data and build the reporting and the analytic work that we needed to do independently of what a hospital needs or wants. So we spend $20 million in buying our own Epic system. And we're beginning to see the results of that.
Yeah, that's very interesting. Well, you certainly have been doing a lot of innovative stuff in Washington and Oregon. And I know that you consult with other folks outside of the state. I appreciate your time and willingness to have this conversation with me. I find it very interesting to take a close look and understand more specifically what other folks are doing to achieve success in the delivery system. I don't know if there's any other final remarks you wanted to make before we call this a wrap, but if so, this is an opportunity.
Well, no, thank you so much for the opportunity to, as I was telling my wife, she said, what is this call about? And I said, well, I think I'm on a vent. And so thank you for allowing me to do that in a formal way.
I appreciate it. Thanks, Carlos. And I'm sure I'll see you soon.
All right. I'll see you at the meeting.
All right. See you soon.
Thanks again for listening to Triage, rapid legal lessons for busy healthcare professionals. New episodes are available for download through iTunes, Google Play, and other podcast applications. By subscribing to Triage, you will receive timely notifications of each new episode. Also, if you have any topics that you would like to hear discussed on Triage, please don't hesitate to email triagesupport@klgates.com. We would love to hear from you.